So now we'll talk about the cerebral ventricles, and we'll say a bit more about cerebral spinal fluid. So this is a drawing looking on top of the brain, so we can sort of imagine how the ventricles are represented. And so we're looking at the lateral ventricles here. Okay, and so we have a large central body of the lateral ventricle, and then we have portions that project into different lobes of the brain. So this is the frontal horn of the lateral ventricle. We have the occipital horn of the lateral ventricle here, and we need to imagine this dipping down into the temporal lobe. And so because this is headed down, this is really drawn much larger than it really is. This should be kind of a smaller temporal horn. But anyway, there it is. So this is a C-shaped structure, as many things are in the brain, which is always important when we're looking at MRI or CT scans. Depending on your image, you may be looking through a C, which means you'll see it. You may see the lateral ventricle here, and then you may see it again way down here in the temporal lobe. Now there's an atrium or trigone right here, which kind of connects the central portion of the lateral ventricle with the occipital and the temporal horns. There's also non-neural tissue, the septum pellucidum, which divides the right and left lateral ventricles. All right, so cerebrospinal fluid is produced actually in mostly in the lateral ventricles, which we're seeing here, okay, but also some is produced in the third ventricle and some is produced down here in the fourth ventricle. Right, so let's start with this ventricle here. Again, we've got a central body, a frontal horn, an occipital horn, and a temporal horn, and then the trigone or atrium is about in this location. So each lateral ventricle has an outlet chamber called the foramen of Monro, or the interventricular foramen of Monro. And so both the right and left lateral ventricles then empty into this space right here, which is the third ventricle. It sort of looks like a bird's head here. So there's a single third ventricle. There are two lateral ventricles. And then from the third ventricle, we have the cerebral aqueduct, where cerebral spinal fluid continues down into the fourth ventricle. So when I mentioned the importance of just recognizing this as a C-shaped structure, imagine we have a coronal MRI here, right? You're going to see the lateral ventricles here and the body, and then the temporal horn down here. All right, so this is a picture from first aid, just showing you here the lateral ventricles getting out through the interventricular foramen of Monro, which are really up higher here. And I would say where they put the dot and called it the foramen of Monro, well, this is really the third ventricle. So, I don't know, move the dot up a little bit, but the third ventricle is right here. And then we have the cerebral aqueduct, and then the fourth ventricle. And then from the fourth ventricle, we have these outlet chambers that allow cerebral spinal fluid to get out of the ventricular system and into the subarachnoid space. So we have two lateral chambers here, the lateral foramen of Luschka, which we see on both sides, and there's a single midline foramen of Magendie. Okay, and so actually these outlet chambers then go out into that cisterna magna space that I told you about, and also then coats the entire spinal cord and the entire brain. So all of this is that important subarachnoid space we mentioned in, just a few minutes ago in the last lecture. So remember, the spinal cord ends at about vertebral body L1 or L2, and so down here we're looking at the lumbar cistern, and this is where you would do a lumbar puncture. Okay, another nice student drawing here. Let's start with production of cerebral spinal fluid in the lateral ventricles, traveling through the interventricular foramen of Monro and into the third ventricle, down the cerebral aqueduct, into the fourth ventricle. And because we're just looking at one half of the brain here, you're only going to see one lateral foramen of Luschka right here, this outlet chamber. Well, actually here we can see the foramen of Magendie right here. It's midline going out into the cisterna magna. Okay, And then all of this is subarachnoid space going down and all the way back up, coating the entire brain and spinal cord. All right, so we have this circulation of cerebrospinal fluid, and then as we'll discuss, this needs to then get out into the venous system. And it gets out into the superior sagittal sinus right here through these arachnoid granulations. Kind of these outpouchings here that allow the continuous flow of cerebrospinal fluid into the venous system. Okay, and then another medical student did a nice drawing of this, so you can look at this again on another representation. Okay, and we already talked about the lateral foramen of Luschka. There are two of them, and a single midline foramen of Magendie. All right, and here is just showing you, here is the subarachnoid space. Now there are these arachnoid trabeculi, which are these little strands that sort of go from the peel layer to the arachnoid. Okay, but all of this is subarachnoid space. And it turns out that the pressure in the subarachnoid space is just slightly higher than the pressure in the venous sinuses. Here we're looking at the superior sagittal sinus. So there is this continuous flow of CSFs through the arachnoid granulations. Right, so what is in cerebrospinal fluid? We said it's produced by the choroid plexus. Importantly, red blood cells, white blood cells do not belong in the cerebrospinal fluid. If you're finding them when you do a lumbar puncture, that needs to be explained because they don't belong there. Equally important, make sure you get this point. Whenever we do a lumbar puncture, we check glucose, but at the same time, we always check glucose in the serum because there is a ratio here that CSF glucose is 2/3 that of blood. And this becomes very important if we have someone, for whatever reason, their serum glucose is high or low. Maybe they have diabetes. And so it's the ratio between these that we always need to be aware of. There's very little protein in cerebrospinal fluid, only 0.5% that of blood, but we do also check the protein content when we do a lumbar puncture. So I've mentioned that the important protective function of the subarachnoid space that contains CSF, the brain literally floats in this subarachnoid space. So it has a protective function, just like when you hit your head or something like that, you don't, tear cranial nerves when you do that because of the buoyancy effect that this provides. And also, and this is probably like 10 years or so, that this lymphatic system has been identified and better described, which is very important for filtering out toxic substances. So this is a perivascular pathway where CSF actually flows deep into these interstitial spaces and just provides a continual bath, filter, flushing out of toxins in the brain. And probably most important is that it filters out amyloid beta. This is something we'll talk about later, but it accumulates in patients that have Alzheimer's dementia. All right, don't spend any time looking at this in detail. It was just such a nice drawing that a student made for me showing you the lymphatic system. Here as the CSF gets in through these virtual Robin spaces, and there are these aquaporin water channels that allow the CSF to get in and circulate, but you don't need to know this. I think it's more detailed than what you need to know at this time. So what goes wrong or what can happen if CSF is not circulating normally? Well, this can lead to hydrocephalus. And I find this always amazing that the choroid plexus makes quite a lot of cerebrospinal fluid every day, 500 cc's about, but yet the total CSF in the entire ventricular and subarachnoid space is only 150 mLs. So what does that mean? This means the CSF must circulate efficiently, continuously, out into the venous system. And if something blocks that flow, if you're still making CSF, but it can't get out, then hydrocephalus can develop. So there are three types of hydrocephalus: a non-communicating, a communicating, and then a sort of a pseudo, not a real hydrocephalus, called a hydrocephalus ex vacuo. All right, so here we have a mass lesion right here. Okay, and let's just say, here are the lateral ventricles. So here is the third ventricle, and let's just say it's right about here, okay, where the third ventricle dumps into the cerebral aqueduct. And so what happens then? Well, you're still making cerebrospinal fluid, but it can't get out and down into the fourth ventricle. So you're going to have a dilation of these lateral ventricles and potentially the third ventricle as well. Okay, and so this we would call a non-communicating hydrocephalus, which just means there isn't communication between the ventricular system. The lateral and third ventricle, in this case, do not communicate with the fourth ventricle. So it's a non-communicating hydrocephalus. And so these patients come in, the brain is under a lot of pressure. This dark area up here is actually edema of the brain. It's very dangerous. And so oftentimes these patients come in with headaches, and you might say, well, let's do a lumbar puncture. Maybe they've got a meningitis or something. And never do that, okay? In fact, we almost always will perform a brain scan before we do a lumbar puncture, because the last thing you want to do in someone with a non-communicating hydrocephalus is to do a lumbar puncture. So remember, in a lumbar puncture, you're putting a needle into the lumbar cistern, you're drawing out fluid. And if you do a lumbar puncture in this patient, you would be creating a dramatic pressure gradient between the lateral ventricles, which are under a lot of pressure here, and then you're lowering pressure in the lumbar cistern, and so the entire contents of the brain could herniate and the patient could die when you do a lumbar puncture. Okay, so never do a lumbar puncture in a non-communicating hydrocephalus. Now, I realize you don't have experience looking at MRI and CT scans, but this is an MRI, and these ventricles are too big. Okay, now, but if I just show you this one section, you would not know, is this a communicating or is it a non-communicating? Here we know because we've got a mass lesion and it's around the third ventricle, cerebral aqueduct, so this has to be non-communicating, but we couldn't tell just from a single image here. Let's just say this is a normal size of the lateral ventricles. So here we have hydrocephalus, and again, this could be communicating or non-communicating. And here we have the hydrocephalus ex vacuo, where we have just atrophy of the brain. So notice the ventricles are big, but the dark area here is the brain just shrinking. Okay, this is atrophy. And when the brain shrinks, the spaces around the ventricles shrink as well. And so don't look at a brain scan of someone like this and say, oh, they've got hydrocephalus. No, they just have atrophy of the brain. It's hydrocephalus ex vacuo. Now, in a communicating hydrocephalus, the mechanism is often scarring of arachnoid granulations. Maybe the patient had in the past meningitis or a subarachnoid hemorrhage, and they scarred off those arachnoid granulations so that the CSF doesn't get out into the venous system very well, and everything backs up into the fourth, third, and lateral ventricles. Okay? In that case, you could do a lumbar puncture. Okay? It's the non-communicating types of hydrocephalus that would be dangerous. So here is an autopsy of a patient with Alzheimer's. Notice the big lateral ventricle, the big third ventricle, but notice also just here's the Sylvian fissure out here. This should be filled in with brain tissue. Here's the temporal horn of the lateral ventricle. The hippocampus should be in here. We don't really even hardly see a hippocampus. Remember, that degenerates early in Alzheimer's dementia. So yes, the ventricles are big, but it's not under pressure, and so we call this a hydrocephalus ex vacuo. Now, well over 100 years ago, it was discovered that when dye is injected, that it can stain all the organs, but it doesn't reach the brain. And that's because the brain has a protective blood-brain barrier. Here's any old capillary in the body, leaky. Okay, the brain has these sort of three protective layers here. And I had the student draw a lock right here on this inner layer, which are the endothelial cells with tight junctions. This is the most important aspect of the blood-brain barrier. Okay, there's also a basement membrane outer to that, and then these astrocytes here, the astrocytic foot processes, also contribute to the blood-brain barrier. Okay, but the endothelial cells with tight junctions is the most important part of the blood-brain barrier. This will have a lot of applications throughout the course. When we talk about medications, we want to know, does it cross the blood-brain barrier or not? And also, we'll discuss things that disrupt the blood-brain barrier. Basically, anything that is a mass structural lesion like a tumor or an inflammatory demyelinating condition like multiple sclerosis. And the reason that's important to know will be really when we get to neuroradiology, where we give frequently contrast when we do an MRI scan of the brain or a CT scan of the brain. And the reason we give contrast is to see, does it cross the blood-brain barrier? It shouldn't. And so if it does, then areas of the brain light up that shouldn't light up. And that can often be the clue that you're dealing with something like a tumor or a condition like multiple sclerosis. Okay, and so we can see here there's some things that can cross the blood-brain barrier freely, and other things like glucose, amino acids that require a specific active transport. Right now, there are areas along the midline that lack a blood-brain barrier. And so I really will only mention, here's the pineal gland here, but I think the most important one for you to know about is right here. It's called the area postrema. Here's the fourth ventricle. So it's along the midline, just in the lower portion of the fourth ventricle. And this is the so-called vomiting center. Okay, so when someone takes a chemotherapeutic for cancer and they have horrible nausea that you have to treat with medications, well, they're nauseated because this area lacks a blood-brain barrier. And so the medication is activating this area and causing the patient to vomit. We'll also talk about a specific neurologic condition later on in the course that involves this area. And also, like when we give dopamine medications to patients with Parkinson's, nausea is the most common side effect because of the dopamine stimulation here of the area postrema. All right, so let's talk about a couple of abnormal conditions here that involve cerebrospinal fluid, a meningitis and encephalitis. And we need to understand what's the difference between these two terms. They're both infectious. As we'll discuss, there can also be an autoimmune encephalitis, but let's just talk about infectious for now. So when we use the term meningitis, we mean there's an infection of the meninges, the cerebrospinal fluid. So we've said the patient will have headache, a lot of neck stiffness, remember those maneuvers that stretch the meninges, and fever. Okay, there are three types of meningitis for now that we'll have you contrast between: a bacterial, a viral, and a fungal meningitis. And so when someone does come in with headache and fever, this is oftentimes your first thing you want to determine which of these three are we dealing with. A viral is benign, you're relieved if you end up making a diagnosis of a viral meningitis. Bacterial or fungal, it's very important we make the diagnosis right away and get the patient going untreated. When we use the term encephalitis, we mean it's not just an infection of the meninges, but that the brain itself is inflamed. There are a lot of overlapping symptoms. These patients will also have headache and fever. Okay, but since the brain is involved, frequently these patients will have seizures. They're more likely to be confused, even in a coma. And we could pick any part of the brain here, but if the language areas of the brain are inflamed, then they'll have an aphasia. If the motor cortex is involved, they may have focal weakness. Now, I won't ask you this for now because we have 2 hours of lecture on brain infections later in the course. I'm just highlighting it now because it's just practical to know as a physician, and also very high yield for boards to know the types of bacterial meningitis by age. Okay, so I won't ask you for this exam, but you may as well just start to get working on this because you'll definitely need to know it by the end of the course. Now I'll talk about one type of encephalitis called herpes simplex encephalitis. So these patients, as we've said, with any encephalitis are going to present with headache and fever. And because it's an encephalitis, areas of the brain are involved. And the temporal lobe is especially involved in herpes simplex encephalitis. And the temporal lobe, as we've said, is the most epileptic part of the brain. So these patients frequently have seizures. Temporal lobe involvement also tends to give personality changes. So they often come in hallucinating. They can even be felt to have a psychosis. Maybe it's psychiatric. But it's usually when the patient has a seizure that everyone knows, okay, well, this is not psychiatric, this is neurologic. They tend to be confused, and because the temporal lobe has important, the Wernicke's area, they'll often have an aphasia. Okay, so we're going to do a brain scan first. I probably should put this here. And an MRI reveals swelling of the temporal lobe, often both temporal lobes. Okay, and then we can do a lumbar puncture because we want to be able to specifically identify that it is herpes simplex and not some other type of encephalitis. So once we think the patient may have this, we right away get them going on antibiotics because you don't want to delay. Untreated, death occurs in about 2/3 of patients. So here's an MRI scan of someone with herpes simplex, and we can see, remember when we look at an MRI, imagine the patient lying on their back, feet coming out toward you. So this is the undersurface of the right temporal lobe. Here's the uncus. And we can see just a little bit of inflammation here in the left temporal lobe as well. So if you see that bilaterally, you'd be quite suspicious you're dealing with herpes simplex encephalitis. Okay, so we do a lumbar puncture in patients that have meningitis or encephalitis. And the things that come back quickly when we do a lumbar puncture are white blood cells, red blood cells, glucose, and protein. And you need to be able to understand when that comes back, what it means, do we need to give the patient antibiotics, and so on. So notice that white blood cells go up in most anything abnormal that involves the meninges, but it's going to be highest in a bacterial meningitis. Okay, in a subarachnoid hemorrhage, you just have blood. Remember that aneurysm ruptures and blood is going into the subarachnoid space, and so the white blood cells are going to enter proportionally to red blood cells. Okay, of course, in the subarachnoid hemorrhage, this is where you're going to have really high red blood cells. Okay, we really don't tend to see that in the bacterial, viral, or fungal meningitis. Herpes simplex, it tends to be destructive to brain tissue, so it breaks down blood vessels, and so we get some leakage of red blood cells into the cerebrospinal fluid. Okay, but I think really the most important thing initially when you do a lumbar puncture is to know what the glucose is. Because our most common dilemma is a patient comes in with headache, fever, and your question is it bacterial, fungal, or viral? And so notice that in both a bacterial meningitis and a fungal meningitis, you have a very low glucose. And so if you're finding that, then you're right away, let's get the patient going on antibiotics. Now there may be some clinical features like a rash or something that will tell you if it's clinically, if it's more likely to be bacterial or fungal. But we're right away in emergency mode to get things going for the patient, to try to get things turned around, even before we identify the specific organism. Notice, importantly, that in a viral meningitis, glucose is normal. Okay, so that is a major distinguishing feature. Okay, we may have a slight lowering of glucose in herpes simplex or in subarachnoid hemorrhage. Typically, though, these are going to be normal, more likely normal. Notice that protein is very nonspecific. Okay, it's rather sensitive, so we're going to get a higher protein elevation in bacterial or fungal meningitis, but glucose is really where it's at initially in terms of pointing us in a specific diagnosis. Okay, other things you're going to do, like to check for culture, for bacterial or fungal, or we can do PCR testing to identify herpes simplex. And then finally, we can do xanthochromia, which I'm going to explain on the next slide. Now, one other important thing to say about glucose, and when we look at lab results, and glucose levels normally in the CSF are between 50 to 75, but remember, we still have to correlate CSF glucose with serum glucose. So let's say we have a patient with diabetes whose serum glucose is 500. You do a lumbar puncture and the CSF glucose is 75, and you look at the normal range and say, okay, it's normal. No, it's not normal because there's a 2/3 ratio. Okay, so if the serum glucose is 500, then the CSF glucose in actuality is much, much lower here than this normal range. Okay, so we need to always compare serum and CSF glucose. Now, what is xanthochromia? What frequently happens is a patient comes in with a headache, you do a lumbar puncture, and you're finding some red blood cells, and you have the dilemma, okay, did I nick a blood vessel when I was doing the lumbar puncture? That's called a traumatic tap. Or is this patient leaking blood into the CSF from an aneurysm? And so we can do two things to figure this out. One is to check for xanthochromia. And when you order that, you're asking the lab to take the cerebral spinal fluid, spin it down. And if the blood has been there for a while, like several hours, like a patient had a subarachnoid hemorrhage, by the time they get to the emergency room and get a lumbar puncture, it's going to be a few hours. What happens is the red blood cells lyse, and they release bilirubin, and that shows up then as positive xanthochromia. So positive xanthochromia would indicate this is probably a subarachnoid hemorrhage. Okay, if you did a lumbar puncture, you nicked a blood vessel, you send the fluid right off to the lab, the red blood cells don't have time to lyse, so you're not going to have xanthochromia. The other way we can do this is when you get to see a lumbar puncture in the 3rd year, hopefully, we drain usually 4 tubes of cerebral spinal fluid. And if you nicked a blood vessel, you're going to find a lot of red blood cells in the first tube, but by the time you get to tube 3, there aren't going to be many. Okay, so this also would tell you, okay, it's a traumatic tap, nothing to worry about.